All right, our first one is a case of achalasia. Achalasia is a failure of relaxation of the lower esophageal sphincter. And the thing about it that I've always noticed is you get the greatest dilation of the esophagus with achalasia. For whatever reason, people that present with obstruction from carcinoma or any other cause just don't tend to have it so long standing that they get this extent of dilation. So of course, the other big concern here is that you not miss a cancer. And so you have to very carefully evaluate that GE junction, right? You want to see a nice, smooth tapering of the distal esophagus. People love to call it a bird beak. But the bottom line is you want to make sure there is no mass causing this obstruction. And again, typically, if you see an esophagus this dilated, it probably is achalasia, but that doesn't excuse you from looking. So here it is on the coronal, and the coronals are, and sagittals for that matter, are very helpful here, because obviously as many views as you can get of that GE junction, the better. Just massive dilation of the esophagus, and they often will present with a food-packed esophagus like this, with the last several weeks of meals all packed in there. So pretty impressive. And you can see that GE junction just does not have a mass. There's a little narrowing there, but that's it. There's no irregularity, and there's nothing extending beyond the confines of the GE junction. Right, so that's a pretty comfortable diagnosis of achalasia. All right, this is a case of Candidal esophagitis. You see that hypodense thickening of the esophageal wall. The impressive thing about Candidal esophagitis is this. It's the extent of its involvement. Almost the entirety of the esophagus is involved, at least in this case. And that is something I really hang my hat on. If I see confluent involvement of the entire esophagus with an apparent infectious or inflammatory wall thickening, I do start thinking of Candida. Other things that will cause this, other infectious causes of esophagitis, reflux esophagitis, caustic ingestion, etc., all these sorts of things will tend to be more focal or segmental. It's pretty rare that you get involvement of the entire esophagus. So my rules are entire esophagus, think Candida. And similarly, if you see the entire colon involved with an infectious or inflammatory process, think pseudomembranous colitis, and we'll get to a few cases of that coming up. All right, here's a case of esophageal rupture. This is pneumomediastinum. You can see it surrounding the aorta and the posterior mediastinum, and there in the anterior mediastinum as well. So when you see that, the assumption is there's got to be a perforation somewhere. It's fairly rare to actually see the spot of rupture, but in this case there's the pneumomediastinum, but look at that. You've got contrast leaking from the posterior aspect of the esophagus. So kind of a rare situation where you can point right at it and say that's where the perforation is. Don't rely on that, and of course also remember it could be tracheal or proximal bronchial rupture as well. So in the case of a trauma, start thinking of those as well. This, of course, the esophageal rupture and fairly low down, is pretty typical for Boerhaave syndrome. This is a patient who was retching or having unproductive vomiting, right, and ultimately ruptured the esophagus. And there is some wall thickening, but as you can see, it's just segmental in the lower esophagus. And that contrast, again, is spilling out into the posterior mediastinum. So that is a case of Boerhaave syndrome and esophageal rupture. Oh, sorry, I was going to give you the lung window on that as well, and you can see the extent of mediastinal gas. The interesting thing is that with Boerhaave syndrome, it's not such a rapid rupture, and so the pneumomediastinum tends to infiltrate all throughout the mediastinum. And that's in contrast to a traumatic esophageal rupture. In traumatic esophageal rupture, it's so abrupt and there's such a rapid expansion of the mediastinal tissues that it tends to knit together and contain that gas collection. So you'll see a gas and fluid collection from traumatic esophageal rupture will be far more circumscribed and not spread throughout the mediastinum as it is in this case. All right, this is a case of a bronchoesophageal fistula. Obviously, it's going to be a little hard to see on the soft tissue windows, but you can see these types of fistulae are almost always related to an underlying tumor, and that is the case here. You've got a hypodense hilar mass with some airspace disease distal to it. Right, but right here is where we've got the bronchoesophageal fistula. So you can see that communication between the proximal right mainstem bronchus and the esophagus right there. So again, usually in the setting of tumors and radiation therapy. And there's that hilar mass with distal airspace disease. Now the lung windows are really the ones that show it beautifully. There you could see that air collection, that gas collection. I'm trying to always say gas. A friend of mine was always pointing out, if you say gas every time, you're always right. If you say air, you're sometimes right. It's probably a good bet that this was air because it's coming from a bronchus and going into an esophagus. But, you know, to be sure every time and be accurate, gas is probably the better word. One of my old attendings used to say, "You're calling that air? Would you want to breathe it?" Always a reasonable question. All right, so that is a bronchoesophageal fistula. Our next one is a gastricvolvulus, and this is a mesenteroenteric or mesenteroaxial gastricvolvulus. And so the whole stomach is twisted on its mesenteric axis. And the thing to really point out here, the most helpful little tidbit I've ever read, is that in these cases, the pylorus and proximal duodenum will be above, superior to the gastroesophageal junction. And that's nicely depicted here because there's even an NG tube present in the esophagus. So you can spot the GE junction, and you can see this is the pylorus and proximal duodenum above that level. So on the cine, you'll really appreciate that. And obviously a very distended stomach because this is effectively a closed loop obstruction. And there is the nasogastric tube in a narrowed esophagus. And we are above the level of the GE junction at this point. So this is a surgical emergency. These volvulus stomachs will get ischemic very quickly. This is one of my favorite findings. This is there's the stomach dilation again. There is the displaced spleen. If you think about spinning the stomach on its mesenteric axis, it can drag the spleen with it. So there is a phenomenon called a wandering spleen. Sometimes the spleen can go off on its own and wander of its own accord, but oftentimes it will be associated with a gastric volvulus as well. So that's a wandering spleen. And you can see right anterior to that spleen is the nasogastric tube entering the stomach. So now we're down at the level of the GE junction. So there is the pylorus and proximal duodenum, and then there's the GE junction. So the GE junction is below the level of the gastric outlet. Right? And that is the classic finding in mesenteroaxial gastric volvulus. And there is that spleen, which has been dragged by its association with the leonogastric ligament. So these patients present with what's known as Borchart's triad, and that's retching or non-productive vomiting, epigastric pain, and failure to pass a nasogastric tube. So a nasogastric tube, failure to pass a nasogastric tube is a suggestion clinically that the person could be having a gastric volvulus. Obviously, in this case, Borchart's triad was not present because they did get the nasogastric tube in I always said when I was an internist, if someone presents with a classic clinical triad, I automatically assume they don't have that disease because the classic clinical triad just about never happens. And that is obviously held to be true here. So that's a nice view here of the pylorus and proximal duodenum located above the level of the GE junction. So that is a gastricvolvulus with a wandering spleen. All right, this one is a case of alcoholic gastritis, and there's not much more to it than extensive hypodense thickening of the gastric folds. Oftentimes, in people with alcoholic gastritis or alcoholic pancreatitis, you'll see a fatty liver associated with it, and that is a helpful little tidbit. But there is the gastric wall thickening. The funny thing about this case is in teleradiology, people complain they don't get the best clinical histories. I think generally speaking, we get terrible clinical histories in any model of radiology that you're working in. But for some reason, people seem to think that we're more exposed to lousy clinical histories than other models. Again, not really true. But this one is to put all those naysayers to shame, because I got the greatest clinical history on this. They said 7 shots of Jack Daniels in 1 hour. So this patient has essentially lit his gastric mucosa on fire, and you can see it's extremely hypodense, swollen, irritated throughout. So that is alcoholic gastritis, 7 shots of Jack Daniels in 1 hour. Don't do that. All right. This is Menetrier disease. It's fairly rare, but it's worth putting in here just so if one comes across, you'll actually be able to recognize it. So this is not so hypodense. You can really see that this is hyperdense fold proliferation, just really prominent, thickened gastric folds with a particular location in the gastric fundus. Note there in the antrum, it really isn't so thickened. So this is just a perfect case of Menetrier disease with gastric fold thickening. There are those that believe this is a pre-malignant condition, so it's not entirely benign, but it usually is going to be an incidental finding. It's typically not something that people are going to present to an ER with. And don't confuse it with Meniere's disease. I called this particular case and I said, I think this is Menetrier disease. And the ER doctor said, well, he can hear fine. So Meniere's disease is of the ear, but Menetrier is of the stomach. All right, this is an interesting, you can get lipomatosis of practically any organ, but I thought this was a fairly unusual one. You're not going to see this too often, but this is gastric lipomatosis. So there are fatty tumors both within the wall and intraluminally. It's just massive lipomatosis of the stomach. And this happened to be an acute presentation of an aortic aneurysm rupture, which you see there, classically retroperitoneal. All right, but our real interest was in that stomach. I don't know. Sorry about that. Let's get that to play. So there you saw all those fatty lipomas in the wall and in the lumen of the stomach. Let's do that one more time through there. And there you go. So that is a case of gastric lipomatosis with an incidental aortic aneurysm rupture. All right, our next one. This is one of my favorite cases, and it's a favorite finding of mine. So you can see there is free intraperitoneal gas anteriorly. So we know there's a perforation. There's free intraperitoneal fluid as well. But here is the gas collection that really matters. It is, right there. There are gas collections in the lesser sac. Right? They are behind the stomach and in front of the pancreas. And that is a very specific location that tells you exactly what's going on. This is a posterior gastric ulcer perforation. I've always noted that in the rest of the abdomen, when you have a gastric rupture or perforation, it tends to bathe all the bowel loops in gastric acid, and they will get thick-walled, just like this. So the inflammation will be apparent elsewhere throughout the peritoneum, especially in gastric ruptures. Obviously, that gastric acid is so caustic. All right, so here are a bunch of little lesser sac foci, see up in the portal region as well. But right there, that's the lesser sac gas. Right in front of the pancreas, right behind the stomach. And again, just like with the esophagus, you're not always going to see the focal perforation, but just the presence of gas in the lesser sac tells you this is a posterior gastric perforation. The portal stuff, the anterior intraperitoneal gas, those are not as helpful, right? They could happen with a perforation anywhere. But right in that spot behind the stomach in front of the pancreas, it's going to be a posterior gastric ulcer. You can even see that on plain film. I have that in one of my Jeopardy games. You'll see that gas on a supine plain film outlining the lesser and greater curvatures because it's trapped there behind the stomach. All right, this is what I looked for a long time. A duodenal ulcer causing pancreatitis. And yes, I did say duodenal. Every once in a while I'll screw up and say duodenal. I think the surgeons made everybody start pronouncing it wrong, but if you think about it, putting the stress on the third syllable of a four-syllable word, that sounds ridiculous. So I'm a fan of duodenum and umbilical. So, all right, back to pancreatitis. Pancreatitis can be very subtle. And this one I would call moderate in degree, maybe even moderate to severe, because oftentimes you can just barely detect the wisps of peripancreatic fluid. This one is due to a perforated duodenal ulcer. Obviously, that gastric acid that has yet to be neutralized will bathe the pancreas if you have a perforation there in, say, the second portion of the duodenum. And so we've got the extraluminal gas right there, clearly extraluminal, but immediately adjacent to the second portion of the duodenum. Right, so there is the inflamed pancreas. Again, that's moderate, maybe even moderate to severe. That's a lot of fluid. And there is a classic location of retroperitoneal gas related to a duodenal perforation. I think the surgeons also started pronouncing centimeters as sonometers, so we have them to thank for that as well. All right. Another duodenal ulcer perforation, and this one just to show you the extent and the little locations where you can get retroperitoneal gas. Sometimes it will track up along the IVC like this one, right? And you can see adjacent to the duodenum here, probably third portion, right? And there is a focal wall hypodensity in the posterior aspect of the duodenum. You can't actually see the perforation, but it's a good bet that it's coming from that inflamed section of duodenum. Okay, so just tune your eye to following the IVC and know the significance of small foci of gas that track up along the IVC and will ultimately be trapped there by the diaphragm. And there is that hypodense segment of duodenal wall that shows you where that ulcer must lie. All right, and that's a duodenal ulcer perforation. This case is an annular pancreas. Usually if you're going to be symptomatic from an annular pancreas, it will happen in your first year or two of life. It's usually infants that present with this, with duodenal obstruction. So oftentimes if you make it to adulthood with an annular pancreas, it's really not so bad and it's probably not going to cause you any problems. So this is a clear exception to that rule. You can see there is pancreatic tissue going all the way around the duodenum. There's a great deal of fluid suggesting inflammation, and there is actually a focal contrast collection, a pseudoaneurysm in the wall of the duodenum. So as best I can put this together, I think that probably this patient had long-standing obstruction of the duodenum, which caused a hang-up of gastric acid and ultimately eroded over time into the wall and created that pseudoaneurysm. So this one is a pretty extreme example. Again, adults are not always symptomatic from these. In fact, I consider this to be pretty unusual. But that is a thick band of pancreatic tissue surrounding this duodenum, and you usually won't see it that substantive. Usually it's just a thin wisp, and it's not even always completely circumferential. I guess completely circumferential is like saying completely occluded, isn't it? Circumferential means all the way around. All right, so that's an annular pancreas with an acute GI bleed.